So this is this whopping great big hole that you were talking about earlier on?
Yes, so this is very similar to what it looks like at work. My screen's about this size. This would be in the middle, and I could see the X-ray on the top left. And so through a combination of X-ray, looking through the endoscope, and this is a 6mm scope, you'll know where you are. This was the ligamentum flavum, which is the entry to the spinal canal.
Yeah.
This is a small scissors, and what you can do is...
So you're going, what level are you going in here, just out of curiosity?
This was L5S1, I think.
Yep.
And this is the entry to the spinal canal here. So this is the last layer of the ligamentum flavum. In a moment, you should, if I get it right, you should see a beautiful blush of epidural fat, which you're just starting to see there.
So that reddish sort of, or darkish stripe at the bottom of the...
Well, actually, it's golden yellow,
right.
But because the light can't get in there yet,
yeah.
It looks darkish. But hopefully I'll put some scissors into that gap in a moment. I'll make a small cut, and everything will just become apparent. There you go. So that's epidural fat. The reason that it's pulsating like that is because there you see.
Yes.
The reason it's pulsating like that is because the scope has irrigation fluid running through it, which keeps the operative field clean and clear, and it also pushes some of the neural structures away, so it gives you a little bit of extra space. And so this space here is, I think that was the interlaminar scope, so that's a 6mm tube that's passing right into the back of the spinal canal. And I've just moved forward. I edited the footage so we could move to the final stages. So you'll see there, this was the discectomy. So that there was a disc prolapse here that was taken out. That's an annular tear. So yep. You can see that there's a chance more disc could come out again in the future, but also that the hydration within the disc can leak out, and so that needs to be repaired. Mm-hmm. And my philosophy is that, if possible, avoid going into the disc, avoid taking the annulus. And if you can do that by decompressing superficially, that would be my preference. And people, when I train other surgeons in how to do this, before they've done a few cases, they always say, well, how do I know I've done enough? How do I know if I've taken enough out? And, well, it's obvious, because once you've done it, you can realize the optics are so good, you can see that the nerve is free.
And just to confirm, we can see a relatively sort of almost square-shaped hole there, and across it there's a band of lighter tissue with what look like blood vessels to me around the outside. Is that the nerve?
Yes. So to orientate you, we're looking in the lumbar spine. The patient is prone, so lay on their front, yes. And the endoscope is placed vertically through the skin in the back. In this situation, we're on their right-hand side, so the patient's head is at this end, their legs are at that end.
Okay.
Midline is here, lateral, the right-hand side is here, and the edge of the facet joint is here. The spinous process, the base of the spinous process is here. The laminar of, if this is L5S1, then the laminar of S1 will be here, the laminar of L5 will be here. Right. And that's the transiting S1 nerve.
Okay.
And
how are you being so precise? How are you guiding your incision?
So you use an X-ray, and depending on what your target is, you can very precisely mark a stab incision. So you lie the patient in the correct position. Right. You aim for the interlaminar window in this situation, and
is the process vastly different for the cervical spine?
The principles are slightly different, but not vastly. You aim slightly more laterally, and again you go for a posterior approach. What you can also do in the lumbar spine and the thoracic spine is go from the side. So you can do a transforaminal approach, and that allows you access to the contents of the spinal canal without going through bone, using the natural windows in the spine.